Good morning.
First of all, if you tell us a little bit about the scope of your work in this particular area.
Sure. Well, actually, I'm a low vision rehabilitation specialist, so basically I perform low vision evaluations. Basically, my work consists of directing a low vision center, the Weigel Williamson Center for Visual Rehabilitation in Omaha, Nebraska. And so this is a comprehensive vision rehabilitation facility where we also have occupational therapists, and we have technology to be able to evaluate and guide people in what types of things can help them use their remaining vision as efficiently and as effectively as they can.
What would you say are the top 3 aspects that patients need to be aware of in going through visual rehabilitation?
One of the first things I would say is that you have to find out about vision rehabilitation from individuals, sometimes other than your eye doctors, because eye doctors are often concentrating on treating the disease, and they actually are not as good about addressing the impairment that is caused by the disease. And that is what low vision specialists are actually there for.
In entering into a low vision program, what should patients' expectations be of that program?
Okay. Basically, what patients should expect is that they are going to get a very thorough evaluation based on the vision that they have. They're going to be able to have someone who is going to test their remaining vision to understand its quantity and quality, and then they're going to guide them as to what types of resources, depending on the areas of daily living where they're having struggle, what types of resources would be best suited for their particular needs and their particular eye condition.
If you look at the advances in low vision rehabilitation, which are the ones that we should be most aware of?
I think the thing I'm struck by, I live in the Midwest, and at this point, my average patient is in their early 80s, and most of them are not using computer devices. But I would say that what I am seeing as one of the greatest innovations is how computers, electronic readers, and smartphones can actually really help individuals with accessibility features and also with apps that can actually give you tools that you would be normally using. You can still use them even though you have vision impairment, and you can use them to go about your daily activities more easily and helping you to maximize your independence.
Which apps are you particularly impressed by?
Well, at this point, there are categories of apps. So for example, magnifying apps can be very, very helpful. Depending on the issues you're having, navigating apps are actually very helpful in terms of helping you to know your location and where you are. There are apps that can actually read the print on the screen to you. There are apps that can help you to distinguish colors. There are apps that can help you to tell the denomination on the bill that you have. I am finding that those apps are changing constantly, and in our clinic, the occupational therapist is the one that interfaces with the individual face-to-face in terms of going over what apps are most likely going to be beneficial to them.
So as part of the comprehensive evaluation that you do with your patients, do you categorize your patients for a specific intervention, or do they move through a variety of interventions?
They actually move through a variety of interventions. Basically, the initial evaluation is one where we get a broader understanding of the areas of daily living where an individual is having difficulty. Then at that point, if it's central vision loss that the individual is coming in to be evaluated for, like macular degeneration, then we will do microperimetry testing, which is where we're actually getting a functional understanding of the central vision. So then that way we can have a better understanding if there are scotomas or blind spots that are actually creating difficulties for reading, because it's more than just magnification that a person may need that help. And then with that understanding, we also then get an idea of how people are adjusting and adapting to the vision loss. So if there are issues of depression or struggles with a degree of anxiety or difficulty because of just feeling out of the game and losing hope, we can assess that, those particular issues. And then we go into the different areas of daily living, and are there non-optical and optical devices that might be able to help them? And then at that point, demonstrating those different types of devices. And there are different categories, whether it's reading or tools for being able to do better with distance vision, or if a person is wanting to use technology such as computers, smartphones, that type of thing.
If we look at some of the neurological manifestations, syndromes such as Charles Bonet syndrome, do you see that in your population?
Yes, we see that frequently. Charles Bonet syndrome is something that in every evaluation that I do, we will always ask if an individual is having difficulty with seeing things in their vision that they know are not there. The main reason that we do that is because many times people are concerned that they're having these symptoms. They recognize that they're seeing polka dots on the wall, or they're seeing a formed image of a building or a person or an animal in their home, and they actually have insight to know that they are not there. It's disturbing though, because it makes them think that maybe there's something going on inside of their mind, and they're concerned to share that with family members. We like to bring that up because it's very common with irreversible vision loss, and we like to reassure them that it is not unusual and certainly not an indication that they need to have their head examined.
Right. So do you have therapeutic interventions as well, in terms of medications that can help that scenario?
Actually, I do not deal with medications for Charles Bonet syndrome. In my evaluation of those things, I haven't found that there are medications that I would recommend for that. Usually it's reassurance to individuals that are having that. Most individuals I know are not dealing with images that are particularly frightening to them or bothersome to them. I have heard that there are some people out there that have symptoms like that. I haven't found that largely in my patient population.
As a fellow, what are the initiatives the AAO is pursuing on the cutting edge of visual rehabilitation?
I think the biggest thing at this point in the American Academy of Ophthalmology, I think right now the biggest issue is for ophthalmologists to recognize the individual that actually would benefit from vision rehabilitation. Ophthalmologists, we're trained to treat the eye. There's a significant problem here though. We miss something, because if an individual has permanent vision loss and we are treating the eye, we can completely miss the impairment that's caused by the disease. So at this point, there is a thrust of presenting more education and raising the awareness of ophthalmologists, helping them to identify which individuals, what patients in your clinic actually you need to specifically ask, are you having difficulty because of your vision loss participating in that activity? Because right now, far too many individuals that could need that help are missed, and they're thinking they're in the hands of the eye doctor. Well, surely they would get them in the hands of someone that would deal with the impairment. But that just is not where it needs to be, and that is a major issue that is being dealt with in the academy at this point.
Dr. Shepard, is there anything else that you'd like to add about projects, programs, future directions of research?
You know, I guess the only thing that I would add is that there are so many different devices that you can run into out there, and in a store sense, can I order something, get it, know if it helps? There is a wealth of resources that are available for individuals that are struggling with vision loss. I truly believe a low vision evaluation is the best way to explore the wealth of those different options. I'm amazed when people come in and they say they have difficulty reading. Some people need just better lighting. Some people actually need magnification. And some people, it's the scotomas that are interfering with the vision. And In one case, an individual needs better light, and there are different types that you can evaluate. Another individual, it's magnification. And do they want to read in bed? Do they want to read at the kitchen table? Do they want to read in the recliner? The device needs to facilitate how they enjoy reading. And so in a low vision evaluation, we can address all those aspects, or we can provide the skill training that an individual would need to minimize the interference of the scotoma, eccentrically view, that sort of thing to better help the individual to accomplish the goal.
Dr. Shepherd, thank you so much for this very illuminating and interesting conversation.
Thank you.